Thank you. Bismillah, alhamdulillah, wa salatu wassalamu ala rasulullah. Thank you, Dr. Mu'tad. Thank you for the speaker, moderator, and the attendees. And a special thank you for Mega Online platform for this very precious invitation to me. And a special thank for Dr. Saad Mahdi and the unseen army behind this work. The second star for today is in our beautiful day of anesthesia day is Prof. Magdy Khalil, Professor of Anesthesia ICU in Liver Institute Menoufia University, former Dean of Liver Institute Menoufia University. Prof. Magdy, well-known figure in anesthesia community worldwide, not just local. His belief that doctor is a student until his death, and if he stops studying, he will die or will be dead. For that, Dr. Magdy just running away to get more learning, more certification, like Diploma of Total Quality Management from American University, Cairo. Also Diploma in Medical Education from Suez University in Egypt. Prof. Magdy is a member of Egyptian Society of Parental Nutrition. The presentation for today, or not just for Dr. Magdy, all the presentation about the safety, and the safety of the patient is our safety also. Safety of the staff and the patient and everyone and the theater. And now the stage for you, Prof. Magdy, to teach us how to be safe in OR for ourselves, for our patient, for everyone.
Thank you. Starting from Saad Mahdi, thank you, Safa, thank you, Yasser, thank you. And thank you, John, for this elegant presentation. I'll pick the thread from the last slide of you to just go through the patient safety and anesthesia practice. If you please, can you all open the camera, because I'd like to share. I have opportunity in my computer to have both the camera and the slides. So I want to share with you, if anyone at the middle of the slides can ask or interpret, please raise your hand and be willing to answer or interact with you. Patient safety and anesthesia practice. Okay. The question starts from the presentation of introduction of Yasser, roles of quality and education in patient safety. Has it a role or no? By default, we are physicians. If anyone come to us, for example, is diabetic, I'll not ask him, please go away, you are diabetic. But I'll start to think in my mind and search in the literature about the treatment of diabetes, the physical treatment of diabetes, the drug treatment of diabetes, the diets of diabetes, and so on, so as he will be safe as a patient. It is exactly what we can do in medical errors due to anesthesia. We cannot say it is inevitable. It is inevitable to be abandoned completely, but easy to be mitigated. I think all of us know about the report of IOM in 1998, example, during the President Clinton. To err is human, this report, what's safety, theory of human error, and I apologize that I might repeat one or two slides from John, dealing with human error and GCI national safety goals. I'll be happy to revise with you my journey in anesthesia. It started 4 years ago. 4 years ago when I was just a resident in Tanta University and smiling Mu'taz. I was so arrogant. I was 57 kilos. I started my steps in anesthesia and ICU till the year 2020, 40 years time. My first lesson in anesthesia was that if you want to be a good anesthetist, you should be a good in physiology, a good in pharmacology, a good in internal medicine, and anatomy to the level to be surgically oriented. This at the time was conventional learning, but was a precious advice. And I still remember this advice up to now. At that time, exactly the term that will be coined to this year, competency-based medicine. It was not, at that time, our information about competency-based education was a little. But now, all over the world, know well about competency-based education. Coming back to air is human, it was reported by the IOM that it was the year 1999 that at least 45,000 of people, as many as 9 people, die in hospital each year as a result of medical errors that could have been prevented. So this was a complaint. We always respected the complaint of the patient, and the patient comes out seeking for the treatment. What was their plan to prevent this many deaths in the hospital? Establishing a national focus, identifying and learning from errors, rising performance standards, implementing safety system in healthcare. These 4 statements or recommendations was about 23 years ago. IOM satisfied 6 domains in quality of care. Acronym STEEEP, but safety comes first. Safety means avoiding harm to patient from the care that is intended to help them. STEEEP, please remind these simple measurement for the patient. Not only it is the most important is safety, but also timely management, effective, efficient, and equitable, and patient-centered. Can anyone please remind me by the STEEEP? We went to Salat al-Asha. STEEEP. Can anyone remind me? STEEEP. All participants sleep?
Because it is a webinar, so the whole mic is closed.
Closed,
So
okay.
unless you want to...
please, I'd like to interact mostly by
chat, maybe? By chat?
By chat. Anyone can come by chat. Please remind me by STEEEP, the 6 letters, STEEEP. Safety first, and then. So I think most of participants are going away. There's a disadvantage of online presentations. Safe, efficient. 2. Amal Shaban said safe. So just remember 2. Time.
Timely.
6. Time. Okay. Coming back to the 6 STEEEP. Safe, timely, efficient, effective, equitable, and patient-centered. Now, I am sure that most. What can we do if some of our colleagues asked about when some bad event occurred? What we do? We are busy with treating the patient, but then after, when you come back to the office, it is the ABC approach. Anyone can tell me about the ABC approach? Even in the chat. ABC approach when coming to the office, not during the care of the patient. Okay. I think Saad is participant clear.
It should be airway breathing and circulation.
No, what? ABC.
ABC is airway breathing and circulation.
This ABC is during the resuscitation of the patient. I said when we come back to the office, what happened to your junior staff if I had made a mistake and he came to your office? Always the ABC approach. A, accuse. B, blame. C, criticize. So the candidate or the junior staff will start to be a liar and not tell the truth. Will not get any lessons from this mistake. So who did it? Not what happened. And the problem is that fault might be repeated again many times. That's because the main focus was on what? He will deny I did a mistake. So this is psychologically. So starting from the teaching from the error is to keep confidential all the event that has been done and try to report and treat. No matter how the fault is small or large, it will end by fatality. This is a safety pyramid which states that whatever the small event, it may lead to death. Okay. The what's safety? Let us to not to identify, let us to come to a specific parameters of safety: identification, communication, medication safety, eliminate wrong side, patient procedure, and so on, infection and falls. If you forget all these 6 parameters, just remind, I can memorize everything I feel. I can memorize everything I feel. So again, identification, if we can summarize all the unsafe events that might happen to the patient, it is identification, communication skills between the practitioners, medication safety has been said, eliminate wrong side, and so on, infection and falls. All of these are the unsafe procedures that might happen to the patient. Let's start about the treatment. Failure to plan is planning the failure. If I'm coming to unsafe, what's meant by unsafe theater, unsafe situation, is that I haven't prepared well the situation. Failure to plan, this is a great wisdom in the field of quality management. Failure to plan is planning to failure. Again, failure to plan is planning to failure. Just for all the audience, we came earlier about 15 minutes during this presentation to prepare with Saad and all the moderators what might happen in the presentations and might mishaps that might happen. We asked for anyone who's absent and so on, just to be ready at 6 o'clock. If we start at 6 o'clock, there might be some problems and the presentation will not go well. So again, please remind by heart this statement: failure to plan is planning to failure. Most quotes in medicine are quoted from Sir Liam Donaldson. He said that to err is human. We all in Arabic, كل بني آدم خطاء. To cover in is unforgettable. But to fail to learn is inexcusable. Fail to learn and fail to treat is up to prevent is inexcusable. Human might have a mistake, but don't cover and don't fail to treat or learn from. This is again the switches model. As we said, there is no small mistake and great mistake. If we are going beyond the scope of medicine, please go to the theory of broken windows. It's a very interesting theory. Broken windows, if you are interested in sociology. Simply, it states that if you leave a small mistake, it will accumulate. For example, if you put a box of rubbish in front of the street and you leave it, the second day there will be a second, third bucket fresh, and third day it will be a collection of bucket fresh. How to reduce accidents? Let's simplify it. Skill-based errors are treated by training. Skill-based errors are treated by training. Knowledge-based errors are treated or mitigated by education. Rules-based errors are treated by policies and procedures. So, like I gave an example in the front, if you have a diabetic patient, so don't say to him, please go away, you are diabetic. You will not be cured again. No. If you have hypertension, diabetic, any disease. So by default, we are problem solving. By default, we are educators. So please keep in mind that by putting in mind that we will treat the human errors is by training and by education, by policies and procedures. What's training? Let's start by training. training. I know most of the MEGA attendees are well in training, but perhaps if they put the training process in academic way, it will give more and more benefits beyond. The action of teaching a person a particular skill or type of behavior. Skill development goes 4 phases: perception, guidance, mastery. Please remind by heart: perception, guidance, mastery, autonomy. Perception, guidance, mastery, autonomy. If you are asking the new resident to start and encourage him to put the intracheal tube without any previous experience, without any disease, he might go well in the first or 2 trials, but he will be taught in the wrong way. So please, any new trainee should pass through these 4 phases. It is not standard timed. For example, you will be taught intracheal intubation in 1 month, 1 year, no. It depends about the learning curve. There are different learning curves, so you will have to give the different curves for this: perceptions, guidance, mastery, autonomy. These are most of the learning facilities about knowledge, skills, and attitude. So we'll go to give an example about the simulation. What is the role of simulation in patient training, in physician training, and also on patient safety? In teaching skills, we have 2 processes: simulation-based training and workplace teaching. Please remind these 2: simulation-based training and workplace teaching. By simulation, it should go through 4 or 3 steps. First one, which coins with perception, we ask the candidate to go the e-learning phase: videos, PDF, simple lectures, or any materials. This is called flipped learning. What's flipped learning? Flipped learning, it is the inverted type of process where knowledge nowadays is not a good way to keep. Flipped learning started in the year 1997. University of Colorado, where 2 professors found that the narration in PowerPoint, we started to give the voice and the writing on the PowerPoint and sent them to the candidate. They found the candidates are interacting during the first phase. So please don't let the first phase of education to be the knowledge. Leave the candidate to search for the knowledge on e-learning before he comes to you. And just to be sure that he has passed good amount of knowledge, give him any assessment. So it is a primary assessment. This primary assessment, we can say formative assessment. It is not put in the last marks. Simulation based has on. Now he comes to the second day, second week, any second time in small group teaching. We cannot say, for example, the hands-on many can about 100 cans. No. The small group teaching, we need more instructors, but the ideal number of small group is from 6 to 8. So divide the can 6 to 8 hands-on, and also a second assessment and on-site observation learning phase, where the third assessment, now the candidate is well enough oriented by any process he might go. But it is not enough. He should go to the theater and do it observable learning phase and do him by his hand in the 4th phase. Just see, this is the learning phase. This is the second phase where he started to do on a mannequin, and then he started observed by his senior, and then he is doing by himself. So if you start by this phase, first line, and just encourage him, you will be enough competent and so on. You might be doing a lot of mistake. I think now, no, I thought this is okay. Yeah. Any from everywhere in the world, great preference. Okay. It is not only the technical skills, as I think Professor Dawlatli has wrote in the chat that myths of communication, or even these are being taught. Don't place that any problem with the junior to be by accidental. If you want to teach him or her how to be a good leader, it should be taught. How to be a team member, it should be taught. How to good communication with his friends, his colleagues, should be taught. So non-technical skills has been written in BGA about 11 years ago, about cognitive mental, like planning, like decision making, that situation awareness, and social interpersonal teamwork, leadership, and communication skills. All these are, and the best of them is to be done by role play. And role play is very difficult to execute and very difficult to assess. If we have done a great workshop, a great training, is it enough? Close the door and go back? No. We should assess the training itself. So anyone other of us who is a trainer, you should, the simplest form of training evaluation is Kirkpatrick model. Kirkpatrick model, 4 phases, and now is a 5th phase beyond the scope of this day. Reaction, where the learner opinion. If they said it is bad, so no need to complete the rest of the evaluation. If it is good, so go to the second way, how learning material has been stayed in the brain of the candidate. How much? How can we assess that pre and post test? And then go back, it is beyond, it is the role of the administrators to judge the impact and the result and so on. And the 5th phase is return on investment, ROI, where we spent the money for this training, how it's going back to the hospital. Workplace education. After we finish our medical school, we go back to the theater. Or during the years of the medical school, we go to the hospital. So it is a broad term that's used to describe building traditional education with experience. We don't finish our education when we come back to the last year of medical school. We start to learn. So it is termed workplace education. And workplace education has many items for assessment. Many 6, DOPS, DBS, MSF, pre-assessment tool. All these are known in medical schools where the candidate should be assessed for his behavior and performance in the theater. Unfortunately, it was after all this effort in the medical school, they found that patient education is not matched well with the results. Results briefly in the medical error, high cost and burnout. What's the problem? The problem is that we spend a lot of money for the medical school, we spend a lot of money of research, but the effect is not as good as we know. The advancement in drugs, advancement surgical techniques has gone away, but the benefit for the patient is less than we expect. So the third payers ask, please give me what is your professions about the medical errors and so on. So medical errors again. The answer is competence-based education. Competence-based education was coined 40 years ago. At the time, I didn't knew any idea about competence-based and just known the traditional learning. Traditional learning where I have to pass 5 years in the medical school, I was 6 years in the medical school, 1 year as a house officer, and so on, and 3 years as a resident, and 3 years as a MD, and so on. It's time-based, but competence-based, it is something which is different. What can you know and can do, not how long it takes. The progress is based on learning ability to prove he mastered the competencies, not just he passed a certain time. Simply, we as say learning as planned experience aiming to permanent change knowledge, skills, and attitude. As you see here, the knowledge fades. Why knowledge is not a mistake? It is intentional to say that knowledge now is not a good deal. I don't have many time to go to the faculty and stay one side outside the theater and say to listen to Magdy, who is saying, for example, the cardiac cycle. Now I can go to the box, the internet, the Google, the PubMed, any search engine to see what is meant by cardiac cycle. When I go back to my professor, I can discuss with him what, for example, the cardiac cycle, what's the importance, how it could be affected by drugs, how it could be affected by, and so on, so on, so on, so on. No, it is a discussion, not a primary knowledge acquisition. However long it takes, you master. So it must going to the time you spent, it is going to the competency you achieved. So competence-based education is a model centered on the student, focused on mastery of competencies based on learning outcomes. So the outcome is defined before the curriculum is done. Here an example of the central venous catheterization, where just to see the way of landmark versus ultrasound. Ultrasound is started by training and workshops and so on, but landmark is the skills of the anesthetist. And this elegant revision about the difference between the landmark and ultrasound guided, percentage of pneumothorax in ultrasound 0, but in landmark, it is 7 cases, about 4%. Atrial puncture, 2, here is 16. Average time, 13, here 20. So we can see that the landmark here is more serious hazards to the patient more than the ultrasound. So it is the advancement of the techniques, the advancement of the base of education. He went through a workshop, he went training on simulators, and then he started doing on the patient. So more safe to the patient. This is a solve a problem. What about, lastly, about the physicians doing this? A golden rule in quality management states that you cannot satisfy external customer without satisfying the internal customer. Who is the internal and the external? If you are doing a flow chart, the one who is benefit from the act is the external customer, and one is doing the act is the internal customer. So you cannot satisfy the patient without satisfying the physician going through. How this, in this revision about IOM, about what happened, questionnaire of 1,508 residents, 40% high risk of burnout, 22% of possible risk of depression. And what is the relation with the patient? The risk factor excessive work was pointed that excessive workload more than 70 hours per week, alcohol or tobacco intake, or female gender. The reflection is that 33 of high risk of burnout and depression who reported making medication errors. Lastly, what about the policy and procedure? We all say that evidence-based, anyone struggling with other, say, please go to the evidence-based. But it was found that evidence-based takes average 17 years to be incorporated into routine general practice in healthcare. It's not so easy. Perhaps for the professors, for the journal readers, it is very easy to capture the guidelines, but for the practice or for the patient side, it takes a long time. Only about half of the evidence-based overreach widespread clinical usage. The IOM have solved this problem by inventing in the year 1981 the bundle care bundle. no need to remind by heart all the guidelines, which is 15 points, for example, but take something with care bundle, 3 to 5 interventions element with strong clinical, should be evidence A, no B. 3 or 5 interventions to be written, scheduled according to the situation of the theater. So I have my own care bundles. John have his own care bundles in his ICU, and so on. And this bundle is used to define patient population or location. WHO has 2 initiatives: hand hygiene and surgical safety, preoperative and intraoperative, and immediately before the patient leaves. And thank you for your patience. And I'm happy to be for the first time with MIGA workshop, and happy to discuss with you the safe anesthesia.
Thank you, Prof. Magdy. For any question, you can put in chat box or question and answer box for Prof. Magdy. But I have a question, because today I feel that my brain about to rupture from this big information, and so I need just in a simple way what we can do in our OR to decrease drug error, or to give a wrong drugs. So you have a policy or just an 1, 2, 3 to tell me to do 1, 2, 3 to decrease this error or not?
Yes, sir.
I think
Again, about drug error, guys.
Yeah,
sorry to interfere here. Yes, sir. About drug
okay.
errors, my lecture is about drug errors. So
okay.
I will go in details into drug errors.
It's okay.
Yeah.
It's okay to mind. Any question? I don't see any question in chat box.
Can I just have a quick? It's a quick comment from before, and we can actually. What I do apologize. I missed a question for دكتور الدولتلي دكتور عبد العظيم. أنا متأكد إن هو موجود معانا هنا، مش كده؟ His question, I mean, if you don't mind, Dr. Magdy,
yes, sure.
if you don't mind. So we don't actually forget about it. There was a question for John from before about, and I think probably it's been covered in Dr. Khalil's lecture. It was a question about saying that the communication is paramount and is very important, and most of the incidents are coming from communication errors. So, John, do you want to comment on this quickly? And then I've got a question for Professor Khalil afterwards. Yeah.
Sure, I'd be delighted to comment. One of the examples I showed was the attending anesthesiologist asking the resident to give 3 of insulin, thinking that everyone knew that meant 3 units, and the resident thinking that's 3 cc's of insulin or 300 units of insulin. Now, anyone in clinical practice for a while knows that 300 units of insulin is an enormous overdose. But if you're just starting out, this wouldn't be the case. So that is an example of a communications error where you should say, give 3 units of insulin. And by the way, that's 100 units per ml. That's an example of how detailed and specific communication is required. An additional area that's a subject of ongoing interest is when someone takes over a case from us to allow us to go to lunch, or to, at the end of the day when the people on call take over, is how well we report what's going on as a synopsis. And that's another communication issue as well. Finally, I point out that there's communication issues from the machines that we deal with. Every once in a while, there is an annoying alarm that goes off, and we can't find out what it is. And it turns out to be the operating room bed rather than part of the anesthesia equipment. It would be nice if the bed would be able to talk to us and say, bed needs plugged in, bed needs to be plugged in. So then we would know what the source of the communication is. So these are potential ways that we can improve communication.
Thank you. Thank you very much. Dr. Yasser, I think Dr. Muhammad Ahmed has raised his hand, so I'll leave you.
Yes, okay, sure.
With him. Yes, and then if you
Yeah.
can come back to me, because I've got a small question to Professor Khalil afterwards. Yeah.
Sure, Dr. Muhammad.
Thank
can
you,
just,
Prof. Magdy,
give
for
me-
this. Okay, thank you, Prof. Magdy, for this very informative presentation. My question may be for both Prof. Magdy and Prof. John. Is it a patient right to be informed with every medical error, or there are some errors that we may not be, may not be mandatory to be informed to the patients?
So I'll comment on this first, because the answer to that will depend on where you practice and what the culture is. And even inside a place like the United States, there can be varying opinions. So if you make a medication error and no consequence happens to the patient, that's different than if you made a medication error and the patient is harmed. But one class of thinkers suggests that all errors should be reported to the patient, even the ones that have no consequence. The concern in the United States is that they may get very anxious about that when there's no reason to be anxious. If you talk to people in the medical ethics community, most will say that full disclosure, regardless of harm to the patient, should be provided to the patient. If you talk to a lawyer involved in medical risk management, they would say, before you do anything, talk to me first so that we can answer questions in a legal framework that does minimum harm to the hospital and protects the interests of the patient. So one thing that some people would say is, whatever you do, talk to risk management first and get details from them. And there's protocols to deal with exactly this.
Yeah.
Yeah.
Thank you.
Dr. Mu'taz?
I think maybe because the question was for both Professor Doyle and Professor Khalil, Professor Khalil might want to comment on the same question as well. That's my understanding from Dr. Muhammad Ahmed. Am I correct?
I don't have adding answers after John, just because it depends upon the legal situation in the country. That might be different from Egypt to States and so on. But if you are speaking about ethical point, if my opinion, if it is harmful to the patient, I should inform him. If it has a consequences after that, consequence might, for example, if I made do some fault and the patient aspirated and he will stay, for example, 3 to 4 days on the ventilator, so at least I have to pay, for example, these expenses. Oh, this is from ethical point, but from medical legal point, I cannot judge exactly. That's because it is different from country to country.
Okay, thank you. I just have a little comment on this, if you don't. I mean, I think we all agree that if there's any complication, any harm, or any complication, whether it's major, minor, or anything like that, the patient has got the right to know, and that's. I think we all agree on this. I think the point of difference is, and that's all over the world. I think you know, ethically, and it's a human right thing, that any complication need to be you know, informed, told to the patient, and any management after this complication has to be explained to the patient. And I should think that this is probably everywhere in the world. The point of difference probably is when trivial things or none, you know, if you make an error and it actually made no difference at all in the process of treatment, in the process of management, whether the patient needs to know about it or not. I think this is where there is probably difference, and I agree with John. The ethical department or the ethical people will say whatever happened, because we should be open and honest with the patient, and part of the openness is to tell them that, you know, I have actually used the wrong device, but it didn't make any difference at all. The problem is here that they might actually have this in their head and think that they can have a complication, and it might be a source of anxiety. Again, different cultures are different. So I just wanted to point this out. The question, or my question for Dr. Khalil, Magdy Khalil, I mean, we've seen an example of ultrasound and landmarks, which is a really good example. So that means we need to be up to date with things to minimize errors. What do you think? Is there room for hybrid techniques? Because I like what we discussed with John. Having electronic patient record looks like it's a big boom, very nice thing to minimize errors, but it comes with its issues as well. So what do you think about a hybrid thing, making use of the old landmarks? And this is an example, in the ultrasound or in venous access, or in making use of the old experience of landmark, and equally making use of the new technology, because there might be room for marrying the two rather than discarding one and going for one. What do you think?
I'll tell my own experience. For example, I'm used to have in difficult airway. I'm used to do blind nasal, but I say to all the junior stuff that now it is abundant. I used it before because there was no fiber optic, but for the safety of the patient, fiber optic is better. If you come back to my slide about the difference between landmark in experienced hand and ultrasound in junior or experienced hand as the same site, you will see a great difference. Today in the morning that I just asked one of my colleagues to do a central line for one of my patients outside my specialty, outside my hospital. By the way, he used ultrasound. And this patient is very lucky. That's because I found an apparent artery in the pathway of the internal jugular. So cannot say that good hands in the old or skillful hands are coming with, for example, 99% success and 1% complication, but with the sonar might goes to 100 success.
Combining them together, yes.
Yeah.
Thank you.
Thank you, Dr. Montez.